We're going to go through these quickly because I know you have them and many of you have already spoken to them on television. Next slide, please. This is a very important slide. It talks about the gatekeeping criteria to moving into phase 1. It's very much related to what you just saw about influenza-like illness. And the United States has been tracking influenza-like illnesses through the Centers of Disease Control for years. Both the state and public health officials are used to watching this, county health officials are used to watching it, and frankly, every family around the United States knows how to access this on the CDC website in order to get up-to-date information to the communities. It also looks at a syndromic emergency room type visits, again, housed at the CDC, and really is our surveillance program that can be utilized for a lot of different illnesses, but in this case will be utilized for respiratory diseases. In addition, we are tracking the number of cases, and it must have a downward trajectory for 14 days, as well as the influenza-like illness and the syndromic illnesses, and a downward trajectory in the number of positive tests with persistence of high levels of testing. For the hospitals, it's to ensure that we can treat all patients without resorting to any crisis care, and ensuring that there's a robust testing program in place for at-risk healthcare workers, including frontline responders with their emerging antibody tests. Next slide. Now, just to show you what this looks like. So what the CDC did for me under the direction of Bob Redfield was to chart what the syndromic illnesses were reporting throughout the early part of March. And you can see in New Orleans, respiratory diseases were starting to be seen in the emergency room. That is the red line. The cases are shown in the dark blue line. The gray mountain is testing, and underneath that is the blue mountain of positives. And you can see that the early alert was present from the emergency room about early respiratory disease. You can see it predated the cases. So throughout the summer, when we do not have flu to contaminate this picture, we'll be able to follow this syndromic pattern, city by city, county by county, community by community, state by state. Next slide. In addition, the CDC has the influenza-like illness net distributed throughout the United States, very useful in the winter time. That first peak is influenza B in the red. That's this season. I showed you all the seasons here so you could see the seasons as they are displayed. The first peak is influenza B, second peak influenza A, and then you can see the coronavirus. And you can see its decline, and it's declining towards baseline. This will allow us, again, city by city, community by community, state by state, to look for variations in an early response mode in those localities that I described. Next slide. So hopefully you see that we've brought CDC and their amazing talent of individuals at the Center for Disease Control and Prevention and all of their abilities to this response and also to the surveillance that we need in this response. But I want to call your attention to the third bullet on this graphic. So we're tracking those two pieces that I described. But the third bullet is about setting up sentinel surveillance sites to be able to distinguish and find asymptomatic individuals. Individuals that you've heard about that may be either pre-symptomatic or asymptomatic throughout their entire disease course. We want to be able to find them in communities of particular vulnerability. So we'll be doing sentinel surveillance throughout nursing homes, throughout inner city federal clinics, throughout indigenous populations, to really be able to find early alerts of asymptomatic individuals in the community, and both for the syndromic cases that are tested, the influenza-like cases, and the asymptomatic cases, doing contact tracing, again with support from the Centers for Disease Control, working with each state and local government. In addition, we want to make sure that all the healthcare facilities have adequate personal protective devices and the equipment to handle the surge and to ensure the ICUs can handle increased capacity. We want every state to have a plan for the health and safety of its workers in critical industries, and to protect the health and safety of those living in high-risk facilities, including senior care facilities, as we discussed with sentinel surveillance, but also additional surveillance. When we talked with all of the states that had not had a major metro outbreak, their sentinel surveillances picked up always the first cases in nursing homes. And so this is a very much a big focus of the plan moving forward. I won't go into the rest of the details on this slide, but there's quite a bit of details on the expectations of every state and local government. Next slide. You'll recognize this slide. Next slide, please. You'll recognize this slide. It's what we've been talking about in the 15 and 30 days to prevent the spread. It's continuing those critical hand washing or sanitizers, not avoiding touching your face at all times, disinfecting surfaces, using face covering while in public, following state and local guidelines, and critically, staying home if you are sick. I know a lot of people go to the workplace when they are feeling ill. You know when you're feeling ill. It won't get better by going to work. So we're asking again for people to stay home when they're sick. Next slide is for employers to ensure that there can be social distancing and protective equipment, temperature checks, use of disinfectant in high traffic areas, including break rooms, and ensuring that we don't do there's no non-essential business travel, and then monitoring for any symptomatic individuals in the workplace. And again, if you become ill at work, to immediately to go home. And ensure that there's contact tracing of all the individuals that become sick. I'm going to go through the phases very quickly, but you have the details. Phase 1. Again, you have to go through those gating criteria related to 14 days of decreasing evidence of illness and decreasing testing despite adequate testing. So phase 1 begins with all vulnerable individuals, including those with comorbidities, continuing to shelter in place, and ensuring that those that first go out into the public are not those that are most vulnerable to bad outcomes in this disease. And then ensuring that we continue to do 6 feet maximum physical distancing in public spaces, continuing to avoid large gatherings, and all non-essential travel. For the employers, next slide. Again, if a vulnerable population needs to return to work and cannot be teleworking, there should be special accommodations for all vulnerable populations, as well as options for teleworking. We believe every employee should encourage work return in phases, from 20% or 25% to 40% to 50%. And again, minimize all non-essential travel. Phase 1 continued. Next slide. If the schools are already closed, they should remain closed. All visits to senior living facilities and hospitals should continue to be prohibited. Large venues, including sit-down dining, can only be operated under strict physical distancing protocols and maintaining those 6 feet. Gyms could open if they, again, could adhere to strict physical distancing, and elective surgeries can resume on an outpatient basis. Phase 2. Next slide. Next slide. Again, you have to go through the criteria again of a continuation of another 14-day decline among those criteria that were in the gating. Again, we're asking for all vulnerable individuals shelter in place. We did not put a timeline on any of the phases. We want the governors, with the data that they have, community by community, to be setting up those timelines. Again, we're asking for the public to continue to maximize physical distance. However, we increased social settings to be able to now have 50 individuals, and non-essential travel can resume. Next slide. This is for the employers. We still would like to encourage telework, and the common areas should remain closed or be physically distanced. All non-essential travel for employees can resume. And then again, special accommodations for vulnerable. Next slide. This should be a relief to many of households that have small children. Schools, daycares, and camps can reopen in phase 2. Visits to senior living facilities, however, should remain in hospitals prohibited. Large venues can operate, but solely under moderate physical distancing, and elective surgeries can resume on an outpatient and inpatient basis. Phase 3. And so phase 3, I won't go through in detail, is essentially returning to our new normal with all of what we talked about through all phases, continuing the good hygiene practices, continuing the respect for spaces between individuals, because we know that we still have an issue with asymptomatic spread. I do believe with this plan that we're both confronting the issue of finding symptomatic individuals through our networks with early alert, as well as those who come and present to different hospitals and emergency room with testing and contact tracing, but critically have put in place what we believe is a safety net through asymptomatic sentinel surveillance that is centered around our most vulnerable groups between nursing homes and our Native American people and indigenous populations, and our inner city groups that we know may be in multi-generational households and of unique risk. I'll stop there, Mr. President.
Thank you very much. Thank you very much, Mr. President, Mr. Vice President. So as you've seen just now from the detailed presentation from Dr. Birx, this is a rather robust program for re-entering into normality. There's a lot of details here, and I know it'll take a little bit of time to digest them all. So what I thought would be good, since I really want to be brief to allow time for questions, is to kind of take us back to the discussions that we've had here before and why this is a natural evolution from what we had said before. You might recall that on a few occasions when I was up here before you, I told you that when we get to the point where we're going to take those steps towards trying to get back to some form of normality, that it would not be a light switch that you could turn on and off. I meant that in two different components. The first of all, that we are a very large country, and we have different dynamics in the country. We have areas of the country that have gone through a terrible ordeal, and others that fortunately have gone and gotten through this rather lightly. So that's the first thing. The second thing is that light switch on and off is the exact opposite of what you see here, which is a gradual gradation with the first thing and the only thing in mind as the health people here, my colleagues who are either physicians, scientists, or public health issues, the predominant and completely driving element that we put into this was the safety and the health of the American public. And I know there are a lot of other considerations that go into opening, considerations that you've heard of right from this podium. But the dominating drive of this was to make sure that this is done in the safest way possible. So let me just make a couple of comments to just reiterate more from a broader standpoint the things that Dr. Birx did so well in a very granular detail. First of all, in order to even consider getting into the phasing, you have to pass a hurdle. And that's the hurdle that we refer to as gating in. Now, when you think about it and look at the map of the country and look at the differences in different parts of the country, you will see that there are some regions, states, locations that are going to be almost already into some of that gating and will have already fulfilled some of those criteria. Others, because of the dynamics of the outbreak in the area, will take longer to be able to do that. But you don't get to phase one until you get through the gating. And then in order to make sure that safety and health is the dominant issue, the design of the phases were just that. You go into phase one, if you get no rebound, and you satisfy the gating for yet again a second time, then you go to phase two. If you have no rebound and you satisfy the gating criteria for a third time, you go into phase three. So there are multiple checkpoints of safety there. So as I've said from this podium, when we were talking about the first 15 days of the mitigation, and then we extended it another 30 days, I essentially pleaded with the American public to say, let us make sure we do the best that we can to accomplish that. And in fact, mitigation works. You saw the charts that the Vice President and that Dr. Birx put up. It worked. And what we hope, and I believe we will be successful, if we carefully do this, again, with the attention to the safety and health of the American public, that we will be able to, it will be staggered. Not every state, not every region is going to do it at the same time. That's clearly obvious because of the varied dynamics of the outbreak. But we feel confident that sooner or later, we will get to the point, hopefully sooner, with safety as the most important thing, to a point where we can get back to some form of normality. The one thing I liked about it that Dr. Birx said so well is that no matter what phase you're in, there are certain fundamental things that we've done that are not like it was in September and October. You want to call it the new normal, you can call it whatever you want. But even if you are in phase 1, 2, 3, it's not okay, game over. It's not. It's going to be a way that we protect ourselves because, as we know, and as I've said from this podium, it may very well be, as we go the cycle around, that there'll be this virus that wants to come back to us. I think we're going to be able to handle that. Thank you.
Dr. Tosh, so I assume that there's also a phase 4, which is after a vaccine is developed
Right.
and available to everybody. So, a question on phase 3 being the new normal. Are we, during that phase, going to be able to see things like packed arenas for sporting events, large crowds, concerts?
The answer is, it is conceivable that we will be able to do that. I think there will always have to be attention to making sure that we don't do all that packing in together. I think we'll be able to have sports events in that phase where you actually have participants there. I'm not sure you're going to be able to do that uniformly and evenly temporally with everyone, but when people get to that phase, paying attention to the fact that if there is a rebound of any sort, that when you're in that phase, you can respond to that, or you put it back and go in the other way. So the flexibility is that there may be some setbacks. I mean, let's face it, this is uncharted water. There may be some setbacks that we may have to pull back a little and then go forward. But John, the direct answer to your question, I do see us getting more towards normal.
I just wanted to, that's why I wanted to put up the syndromic and the influenza-like illness piece, because what is key in this is the early alerts and getting in there before they even know they have a problem. And I think CDC has been remarkable in building these platforms. Dr. Redfield integrated them, so they're all on the same website. If you look at COVID-19, go into cases, you can find all of the data. And the beauty of it is the states are used to utilizing that through flu season. So the testing and contact tracing, and Dr. Redfield will be putting people in every single state to make sure that CDC is standing beside the state and local health officials to make sure that all of those cases are immediately identified and contact traced. I think what's new and what's really critical is this constant sentinel surveillance for asymptomatic individuals in communities that we know are particularly vulnerable. And that hasn't been done in flu before. And I think that's going to be the added dividend that's really focused on who is most vulnerable and how do we get the fastest alert by generally screening people without symptoms. So people who are just coming to the clinic will be screened for COVID-19. And we do have enough testing capacity to do both that surveillance piece as well as the diagnostic piece and contact tracing.
Just a follow-up. You want to say something?
No, actually, people have gotten confused about that because in the beginning when we were focusing really on just mitigation and really trying to keep peaks down and trying to worry about ventilators and PPEs and things like that, when you get a little bit more grace period, you can start figuring out what is the penetrance of this virus in society. What are we missing in people who might be infected? What is the percentage of those people that are out there? That's going to inform us greatly for a number of things, including the level, once we prove that antibody test that you have is really protective, and we still don't know that yet. We're going to find that out. We may get a good feel of what the level of protection might be in society, but we don't know that yet. So it's going to give us information as to what the vulnerable areas are and how we need to respond. Remember, there's two types of things: antibody tests and tests for the diagnosis of who has the disease. One you need for contact tracing, the other you want to need for finding out what's in society. We're going to have both of those much, much better as we go in the next weeks and months. And by the time we get into the fall, I think we're going to be in pretty good shape.
Thank you, Mr. President. I think what's really important is during this bringing the people back to work and our economy back to work, and what's going to go back is that we're going to be very aggressively focused on early case recognition, isolation, and contact tracing. In the event that we just went through, unfortunately, as we started, we were very capable of doing that. When the initial cases all came from China, all the way through January, all the way through to the end of February, we were able to identify cases early, the first 14, do the contact tracing, over 800 contacts. We identified that 2 of those contacts were actually infected. We were able to isolate them. We were able to contain the outbreak. We're about to enter a new phase of this where we're going back to containment. And mitigation is going to continue, as Dr. Birx and others have said. Some of the things that we've learned to do, we're going to continue. But the major thrust of how we're going to control and make sure that we continue to keep this nation open is early case recognition, isolation, and contact tracing. That's the fundamentals of public health. That's what we're going to do. You see, we have very good surveillance systems that are going to help us. As we see these cases sporadically across the country, we've got to jump on them with early diagnosis, isolation, and contact tracing. That's what CDC is going to continue to help build that capacity in the states across this nation.
For those states that aren't ready to go to phase 1, to get through these phases, do we have an idea of how many millions, tens of millions of tests they're going to need for them to get through these phases?
Yeah, so I mean, you've heard me talk about tests for a while from the podium, and I think what has happened over the last several weeks is hospitals and clinics that could move to the more point-of-care test, move to those point-of-care tests. And what it's left is an amazing array of capacity that exists in the country for at least 1 million more tests per week. So we have a whole team working lab by lab to see what it would take to turn on all of those labs that aren't running the pieces of equipment now. So you see in the system, I just said to you, there's 1 million more tests per week, that we have tests sitting there and equipment sitting there, and now we have to really deal with each single lab to really figure out what they need. And I just want to thank Administrator Verma, Seema Verma, who went through with us, and thanks to the lab directors, they really explained to us highly technical difficulty to run some of these big pieces of equipment, because you have to aliquot the samples, you have to centrifuge, you have to put them on the machine. It takes a tech full-time. At $50 a test, it wasn't enough to hire another technician to run the machine full-time. So at $100 a test, it is. So those are the kinds of changes we have to make bit by bit by bit. But that alone doubles our testing capacity per week. So we're committed to work with laboratories to answer every one of their issues with the state and local governments. And I think, frankly, every conversation I have, and the governors will say, I need 5,000 people tested. And I say, well, at the University of X, there are 6,700 tests waiting for you. So it's more of making sure that every governor and every public health official knows exactly where every lab is and where the tests are, so we can create with them a real understanding so all these tests can be run. So yes, there is twice the capacity right now.